what we have yet to learn, and particularly the second part of that, because as you'll see, we have much to learn. And there really aren't a lot of data on asthma and long COVID in particular, but still, I think a lot that we can talk about in general about these two conditions and how they interact. I will note that I'm not alone in this presentation. There are three people who are joining me: Deborah Brewer, 54-year-old woman from Burlington, Ontario; Emma Hoberg, 24-year-old woman from Squamish, BC; and Leanne DePoint, 44-year-old woman from Orangeville, Ontario. All three of these women are long COVID sufferers who have been very gracious and generous and have shared their story. And so you'll be seeing video clips from them to help contextualize some of this information. And I think some of the people on the call may be long COVID sufferers as well, and we'd love to hear from you at the end of the talk as well. And so we'll be talking today about two common problems: asthma and long COVID. And I'll put some numbers on that. Asthma, obviously, for this audience, you know that asthma is very common. In Canada, 1 in 3 people will be diagnosed with asthma over a lifetime. It's the third most common chronic disease in the world. It affects about 8% of the Canadian population, which amounts to almost 3 million people. And the annual economic burden as of several years ago was already $2 billion a year. More than half of prevalent asthmatics in Canada do not have good control of their disease. So they continue to suffer with significant symptoms and don't have good control of their asthma. Now, COVID. This is the Johns Hopkins dashboard from just a few days ago. And you can see here that if you look at the worldwide burden, we're looking at 535 million cases, and people out there know that these are underestimates. Even in countries like Canada, we're no longer really measuring cases. So many more people than this would have had COVID, and the deaths are approaching 6.5 million now. And this has been a disease that, as you know, people in the audience know that this is a disease that's been characterized by this frustrating propensity to attack many different organs and many different systems in the body, more so than we've seen really with pretty much any virus that we've known before, although the caveat being that this is the best studied virus probably ever as well. But thinking back to where this notion of long COVID came from, how did we first learn about it and discover it? Think back to March of 2020, which was a challenging time. It was a time before vaccines. The world was in upheaval. There were hundreds of thousands of people being infected daily and already infected. And a number of people started noticing unusual symptoms that lingered after their acute infection. And as it turns out, this term that we use now quite commonly, long COVID, started out as a hashtag on Twitter. That's where this originated. And this is the world we now live in, where new diseases, new findings often start by people sharing their stories on social media. And today, this is now a recognized medical condition. It's also called post-acute sequelae of SARS-CoV-2 infection. It's called post-COVID condition, chronic COVID syndrome, or long haul COVID. You would have heard it called any one of those names in sort of lay terminology, but also in the literature. And it has a few different definitions. These definitions are finally going to converge soon. But the World Health Organization defines it as symptoms for more than 3 months after onset of the acute COVID illness, lasting for 2 months or more. More commonly used definitions from the CDC in the US and the NICE in the UK are people having symptoms for 4 or more weeks after the onset of the infection. It's important that there's no alternative diagnosis that could explain those symptoms, and this is where it becomes interesting to think about the role of asthma, particularly because, as you'll see, many of the symptoms of long COVID are respiratory symptoms. And finally, important to recognize that in some people, they get sick and their symptoms persist, but in other people, they get sick, then they get better, and the symptoms come back. And that also is long COVID, and sometimes several weeks after the initial infection, they can develop very typical long COVID symptoms, and then those symptoms will persist. So before we get into long COVID and asthma, I want to start with some context just on COVID and asthma. What do we know about how these two conditions, acute COVID and asthma, actually interact? So just from a sort of process point of view and disease point of view, COVID-19 is a disease of inflammation. When people get sick from COVID, it's because they have significant inflammation in their body. And we also know that patients who have poor asthma control, it's because they have inflammation in their airways. So there's a sort of process and pathway commonality there. Early in the pandemic, we considered asthmatics to be an at-risk population on a theoretical basis because we thought it would be kind of like two hits if they got COVID. They would have the viral infection. Because viruses often trigger asthma exacerbation, we thought they would also get a significant asthma exacerbation, and that might make them more likely to have severe COVID disease and end up in hospital, end up in the ICU. As data gradually accumulated, though, there was a question about whether asthma might actually be a protected population because it seemed asthmatics were less likely to get really sick from COVID. And so there have been lots of studies published on this, and I would say the literature has sort of moved over time, but I'm going to present the most recent review that I found, which was from this year, looked at 51 different studies, looking at the proportion of people who were hospitalized who had asthma, hospitalized with COVID. About 8% of those who were hospitalized with COVID had asthma, which is similar or even a little bit lower than the local population asthma prevalences in the studies that this came from, which implies that asthma patients are no more likely to end up in hospital than anyone else in the general population. Interestingly, that's hospitalization, but interestingly, for risk of actually just getting the infection, that risk was lower in the asthmatic group than the non-asthma group by 17% or so, which was interesting. And there were no statistically significant differences for hospitalization, as I mentioned, but also for ICU admission or ventilator use. And they concluded that asthma doesn't increase risk for severe disease, maybe decreases risk for any infection, but certainly not an increased risk. And that's actually in contrast to other viruses. And we know that, for example, when we have flu, maybe pre-COVID flu are the numbers we really should look at when we had a lot of flu. At any one time in the middle of flu season, if you look at US data, 20% of those hospitalized with flu had asthma. And that just tells you that patients with asthma were more likely to get severe illness from influenza, but that signal just didn't emerge with SARS-CoV-2 or COVID-19 disease. There are some theories on how these two conditions interact. One theory around why maybe asthmatics were less likely to have the virus or at least be diagnosed with the virus. It could be because the symptoms of acute COVID and of asthma are pretty similar, and many times asthmatics may have ascribed their symptoms to just their asthma and not sought care, and then just had a mild infection, gotten through it, and never known about it. It's possible we're just detecting it less in patients with asthma. Also, it's important to note that although flu tends to trigger severe asthma, seasonal coronaviruses typically don't contribute to significant hospitalizations from asthma exacerbations. And after all, this is a coronavirus, and it may soon be a seasonal coronavirus. Inhaled corticosteroids have an interesting role. We know people would know that in those who are not candidates, for example, for first-line therapies like Paxlovid and remdesivir, we often give budesonide as a treatment for SARS-CoV-2. There are some data to support it. And of course, patients with asthma are often already on an inhaled corticosteroid, and that anti-inflammatory effect might mitigate the severity of the SARS-CoV-2 infection. There's also a theory around what we call the ACE2 receptor, and that's a receptor found in our cells of our airways, and it's thought to play a role in how the virus enters our cells. And so inhaled corticosteroids might decrease expression of that receptor, which might have a protective effect as it decreases entry sites for the virus. We also know that ACE2 expression is generally lower in people with asthma compared to other people, and that's particularly true in people with allergic asthma. So here are some of the mechanistic reasons why people with asthma are at no higher risk for severe COVID and perhaps lower risk in general for bad COVID outcomes. But let's go back now to long COVID and first talk about symptoms. So here's a cartoon depicting the various different symptoms. And as you can see, many, many symptoms have been reported from long COVID. And sort of the size of the bubble tells you the frequency of the symptom. Now, there's an interesting analysis that was done from the UK study, REACT-2. This is a big long COVID analysis. And looking at different symptoms that were reported by thousands and thousands of patients, they did a statistical analysis that popped out sort of two clusters, sort of types of symptoms that cluster together that people present with. One was the tiredness cluster, so-called, and those patients had a high prevalence of fatigue with muscle aches. They had difficulty sleeping. They often had shortness of breath. And the other was what they called the respiratory cluster. And these are people who had a lot of respiratory symptoms like shortness of breath, tightness of the chest, and chest pain. What's interesting there is you see shortness of breath in both clusters, and that is a very common symptom with long COVID disease, and of course, a very common symptom with asthma. So you're starting to see that overlap that we see in symptoms. Here's Emma, who's describing her symptoms.
I never feel like I can catch my breath. I can't exert myself for anything. Like I can't, when my breathing's bad, I can't cook and clean. I can't, like essentially just have to rest until it rides out. But even resting doesn't really resolve it. Like sleeping sort of helps, but I'll still wake up like short of breath, and then it never. Like maybe I'll have one or two good days, and then I'll hit a wall and have maybe 5 to 6 really bad days, and then I'll start to get better, and then I'll do a bit more, and then I'll get worse again.
And so a lot of those symptoms are more specific to long COVID, like the fatigue component. But as you can see, there's a strong theme that emerges around shortness of breath, which of course is something we hear all the time from our patients with asthma. Here's how Leanne described it.
Shortness of breath, especially dyspnea with minor exertion. My voice continues to go hoarse. I have brain fog and extreme fatigue. At the 6-week mark, I required to go to the emergency department. As a patient, I had a pre-syncopal event. I couldn't say more than 2 words without coughing. I was so fatigued from coughing and having difficulty breathing. And the fatigue, I was still sleeping at least 4-hour naps during the day and 12 hours at night.
So again, there's that component of fatigue and brain fog, but there's also a strong theme that emerges around shortness of breath, urgent healthcare use, trigger-related symptoms, and again, all of this is going to make us think about asthma in the context of patients who are presenting with long COVID. And so there are some important consequences of that overlap in symptoms. A couple of different ways we can think about it. In patients who don't have asthma, when they get their COVID, if they start developing symptoms of long COVID, again, because of that overlap, they may get misdiagnosed with asthma. They might actually get treated for asthma on speculation, but really it's been long COVID the whole time. At the same time, though, we must recognize that that respiratory component of long COVID, in some patients at least, might actually be asthma. And it might be that they hadn't received a diagnosis of asthma previously, but like in many cases, when you have a bad viral illness, is when the asthma becomes manifest and becomes obvious to the person and becomes very symptomatic. So it could be a misdiagnosis of asthma that occurs in some of these patients, but in some patients, it might be an actual diagnosis when the COVID process, the COVID disease, actually brought out or uncovered the asthma. On the other hand, in people who have known asthma when they get their COVID, they develop symptoms of long COVID. Often those lingering symptoms, at least the respiratory ones, will be ascribed to the asthma. Could be falsely ascribed to the asthma, could in fact be all long COVID, which we don't quite understand, but not necessarily symptoms from the asthma, but more so from the effects of the virus on the body. On the other hand, similarly, that respiratory component of long COVID may actually be the existing asthma triggered by the virus. So it might be true and it might be real that at least the respiratory symptoms in a patient who had asthma when they got their COVID disease, those persistent, longer-lasting respiratory symptoms could be a manifestation of poorly controlled asthma that was triggered by the virus and would actually respond to asthma therapy. So as you can see, depending on whether one had asthma or did not have asthma when they entered their COVID illness, there are lots of different ways we might have to think about this if they develop respiratory symptoms as part of their long COVID. How often do we actually see long COVID? This is a question that there's a lot of debate and discussion around right now. I'm going to show you 2 of the biggest studies. This is a Danish cohort. Very important when you look at incidence data around long COVID to always have a comparison group. And because a lot of the symptoms are nonspecific, like fatigue and muscle aches and poor sleep, one of the criticisms has been that if you just go out and ask a bunch of people who have had COVID if they have those symptoms, you'll get very high rates. You'll get 30-40% of people saying, sure, I feel that. But you always need a comparator group because those are pretty common symptoms in the general population. We're all tired. We're all fatigued. And so it's important to have that comparison. What they did is they looked at about 150,000 people who tested positive for COVID, and their comparison group was just under 92,000 people who tested negative for COVID. And they looked at the difference in the frequency of symptoms between those 2 groups. And if you look at the prevalence of having at least one symptom 6 to 12 months after your initial infection, so a longer period than most would use to define long COVID, About 30% of people who tested positive had at least one symptom, but only 13% of people who tested negative. So that's the risk difference. And that's what we should be looking at. And that risk difference is in that 15 to 17% range, where that's the increased burden that people are experiencing out there as a result of their COVID illness. That risk difference was significant across most symptoms, and I'll show you that in a moment. Importantly, and you'll see this across the long COVID literature, the symptoms were more prevalent and more severe in patients who were sicker. Patients who were hospitalized were more likely to have long COVID and more severe long COVID compared to people who were not hospitalized. But important that non-hospitalized people with mild disease, many of them can get long COVID. And quite consistently in the literature, you'll also see that long COVID occurs more frequently in females than in males, or at least diagnosed more frequently. This is what the risk differences look like in that study. It's sort of, there's a lot of information here, but just to show you that if you look at any one symptom, in this first symptom here, dysosmia or a change in sense of smell, the risk difference was 11% between people who tested positive versus negative. And this dotted line is sort of the no difference line. So you can see that there was a significant difference. Many more people had changes in their sense of smell, sense of taste, fatigue, exhaustion, shortness of breath, weakness, all of these. And so for most of the symptoms, you can see that there was a significantly higher proportion of people who tested positive who reported these symptoms 6 to 12 months later compared to people who tested negative. Another way that this has been looked at is by looking at electronic health records, and that enables a much bigger data set. And this is actually a data set of over 250,000 COVID survivors in the US. What they did, which I think is also important, because again, coming back to some of the knocks on the long COVID incidence literature, is that people say, well, we're studying this virus in a way that we've never studied other viruses. How do we know that other viruses don't also cause long-term symptoms? We just haven't bothered to measure. And so they actually said, well, let's look at influenza then. And they actually matched these 250,000 or so COVID survivors with people who had influenza and tried to compare long-term symptoms in COVID survivors versus influenza survivors. And what they found was that of the 9 typical long COVID features that they explored, all 9 were seen significantly more frequently after COVID disease compared to influenza disease. And that overall excess incidence, the difference in these symptoms after COVID versus influenza, was 16.6%. So this 15 to 20% range is what you're going to see quite consistently across studies. Now, if you add that up, it's more than 80 million people around the world expected to have long COVID. In Canada, I estimate that to be more than 1 million, not based on just numbers, because case numbers are vastly undercounting now. But if you look at some of the seroprevalence data from Canada that estimates how many people have had the virus, we're looking at 1 million people expected to have long COVID. You can imagine now what kind of burden this would have on our healthcare system. The only caveat I'll mention here is that a lot of Canadians who were infected in the latest few waves, the Omicron waves, and most of those people were in fact vaccinated. And that's important because, as I'll show you later, the likelihood of them developing long COVID if they get the virus when already vaccinated is lower. And so we might see a little bit less of a burden, but still many, many people who are going to be facing long COVID and impacting our healthcare system in that way. Now, is this incidence, the likelihood of getting long COVID, any different in patients who have asthma? So this is a tough question, and we don't have a lot of data, but there are 3 studies that have asked this question at least. Here are a couple of early observational studies. So here's a cohort study that looked at, small study, 74 asthmatics who had COVID, quite a sick cohort in that 1/5 of them had been hospitalized with COVID, which is more than the typical hospitalization rate. And they looked at them 3 months after the infection, and they found that only about 10% had long COVID at that 3-month mark. And that's lower. We just talked about a sort of 15 to 20% expected incidence. And so the question from that study was, is it possible that asthma is protective against having long COVID? One other note from that study is that they did have a lot of hospitalized patients, and there was what we call an incidence gradient that is similar to what we've seen in the non-asthma data, which is that, as I mentioned earlier, the sicker the patient, the more likely they were to have long COVID. So that was maintained in the asthma cohort, but the overall incidence of long COVID was pretty low. It was only 10% of those patients. Now, there's another study that was done through survey. This was a bigger study. It was actually a survey of asthma patients. They were surveying 4,500 people in the UK with asthma, and they had serial surveys. And then COVID happened, and they decided to start asking questions about COVID. And they found that about 10% of that cohort happened to have had COVID, 471 people. And then they asked them how many of them had long COVID. And out of that cohort of 471 people who had COVID, more than half self-reported long COVID. So here you have the first study saying maybe 10% of people with asthma get it. Here you have another study saying more than half of people with asthma get it. You can see that these are small studies, and obviously there are methodological concerns there. They're observational studies, and we're not validating the diagnosis, but already wildly different estimates from the small studies that we have. This second study actually did a qualitative analysis of the kind of information people were entering, free text entering in the survey. And very interestingly, the themes that emerged were that people recognized a very important overlap in symptoms between their long COVID and their asthma, which is what we've already talked about, and that very important interaction that they recognize between COVID-19 and asthma, whether it be symptoms, whether it be treatment. And so, really challenging, I think, for us as clinicians to understand those differences and to treat people appropriately and to target the right condition when we're facing people who have both asthma and long COVID. Finally, I'll mention a little bit of a stronger study design, which was a case control study. Again, very small. They looked at 61 people with asthma who had COVID, and they matched them to just over 120 control people who did not have asthma but developed COVID around the same time. And what they found was that during the acute infection, people who had asthma had more likely to have shortness of breath and muscle aches than people who didn't have asthma. So there were some differences in the acute presentation. And then 7 months after the infection, so quite long period after infection, they did a typical long COVID questionnaire. And what they found was that those who had asthma versus those who didn't had a very similar prevalence of long COVID at that 7-month mark, that sort of cross-sectional look at 7 months. And each symptom that they asked about was similar, except for dyspnea, of course, which was more common in the asthma patients. And that's not surprising. And here again, you're getting to that confounding in symptoms where the asthma confounds our assessment of long COVID symptoms because, of course, dyspnea or shortness of breath can be seen in both. And so this study suggests that maybe it's similar. Maybe you're more likely or less likely to get long COVID if you have asthma, but definitely we need more work in this area. And the other caveat is that all of these studies were done before Omicron. Many of you know that we have an understanding that different variants are more or less likely to cause severe disease. They have slightly different patterns of the kinds of symptoms that they cause in people. So the question is, do different variants have different likelihoods of causing long COVID? And we don't know. We don't really know the answer to that yet. And we don't have a lot of data on long COVID from Omicron because it's pretty new. So all of that is still emerging. Want to touch quickly on the consequences, objective consequences, pulmonary consequences of long COVID. We have some data here. I'll show you one of the bigger studies, which was a review of 15 small studies looking at objective testing like pulmonary function testing and CT scans in patients who had severe COVID. So these are patients who were hospitalized, and then looking at them 1 to 6 months after they left hospital to see if they had any abnormalities after the COVID infection. They looked at almost over 3,000 people. Disappointingly, more than half of those people on a CT scan had some abnormality, whether it was a little bit of ground glass change, which is a sign of inflammation or infection, or scarring, parenchymal bands, as we call them. More than half had those kinds of changes. Almost half had some type of abnormality in their pulmonary function testing. And in fact, over a third had a low diffusion capacity, which could be a sign of scarring. So again, very common to find abnormalities both on imaging and on pulmonary function testing after a severe COVID infection. One caveat, we don't have pre-COVID pulmonary function testing in these patients. So it could be that many of them already had abnormalities and we're just now picking them up because we're looking. It has nothing to do with the COVID. But to be fair, only 4% of those people had known lung disease. So it's unlikely that this proportion of them would have had abnormal pulmonary function testing and CT scans, and very likely that the severe COVID illness had something to do with that. Important to recognize that these are sicker patients who are hospitalized, but we are starting to get some data in non-hospitalized cohorts. And it does look like 10 to 15% of people who get milder COVID, who are not hospitalized, if we go out and measure their lung function afterwards, 10 to 15% have a low forced vital capacity. So they have signs of an abnormal spirometry, but the majority will not have that objective finding. They'll have a normal spirometry, despite that they'll be very short of breath, which is, again, one of the common symptoms of long COVID. And important to recognize that when we see these patients and they have these respiratory complaints, we put them through typically the full gamut of cardiorespiratory testing. And here's the experience that Deb shared with respect to her testing.
I was sent for many different tests. I had 2 CT scans with contrast. I had EKG, lots of blood tests. I had an exercise test, respiratory tests, asthma tests, breathing tests, and all of those tests came back negative as if nothing was wrong with me.
And so you can see that first the degree to which we test people, but also the frustration that people feel when they have symptoms and don't have objective findings on testing. Talking quickly about prevention, how do we prevent people from getting long COVID? Not specific to asthma, but from the data we have from long COVID in general. Obviously, if you don't want to get long COVID, don't get COVID. I think that's becoming less and less likely that many people will be left who don't get COVID, at least people who choose to reintegrate into society, which is going to be most people. And if we accept that most people are likely to get COVID at some point, particularly with the variants that we currently have, it seems like getting vaccinated before getting COVID is helpful. These are data from the UK Health Security Agency from February, where they reviewed about 15 studies. They found 6 studies supporting the notion that vaccination has a preventive effect for long COVID. And whether they got 1 or 2 doses, people were less likely to have symptoms at the 4-week mark, but also importantly, out to 12 to 20 weeks and out to 6 months plus, so long COVID. And in this study, they estimated that it was probably in the range of a 50% reduction in the likelihood of having long COVID for people who had vaccination. There are more recent data. People might have seen a paper in Nature 2 weeks ago that suggests that the effect might be smaller. It might be in the range of 15%. Regardless, there does seem to be a protective effect. It may not be a massive protective effect, but there does seem to be a protective effect if you are vaccinated when you get your COVID disease. Quickly on treatment, we don't have good data. We don't have proven treatments for long COVID, but there is a possibility that vaccination can play a role. This means your first vaccination or you're getting a booster shot after your COVID disease if you have long COVID. Again, UK analysis found that 3 out of 4 of the studies they reviewed found an improvement in symptoms of long COVID after vaccination. And that improvement in some cases happened very quickly, over days. In other cases, it took a few weeks. But the improvement happened more often than the worsening. The caveat, however, is that each of the studies did report some patients who got worse. Their long COVID got worse after they received a booster vaccination. So that's something we have to be wary of. And most people, 70% or so, remained unchanged. So I think it's not something that we can tell our patients is very likely to improve their symptoms. But of course, there are the other benefits of vaccination. But we have to always warn patients that there's a possibility their long COVID could get worse. And another possible treatment that's emerged right now, more just anecdotally, is Paxlovid. Why might vaccination help? Well, there's some theories around why long COVID exists. And one theory is that it has to do with dysregulation of our immune system, maybe even autoimmunity, our immune system attacking our own body after being triggered by COVID disease. And vaccination might improve that dysregulation. Vaccination might put things back to normal by creating a sudden massive immune response. The other theory is that there are possibly viral reservoirs after infection. You get your acute infection, you get better, but there's still some virus that hangs around in your body. And by that theory, Paxlovid might be an interesting drug because, of course, it's an antiviral drug, and that may be the mechanism by which Paxlovid seems to have helped, at least anecdotally, some people. Again, we need more data. Just going to describe to you how the experience that Deb had after her vaccination.
At about 17 months, I had my second vaccination. And after that, I noticed a significant change in my symptoms. Quite a few of my symptoms subsided after about a 2-week period. And I started to feel a whole lot better. probably about 85% better and almost normal at that point.
So here's someone who suffered from long COVID for a very long time and was one of the lucky people who had a significant improvement after vaccination. Not a full resolution, but a significant improvement. How do we support our patients in the context of the fact that the evidence is still growing, our knowledge base is still growing? We don't have answers for most questions right now. There are many and growing a growing number of long COVID programs. In the US, I last counted 66 different US hospitals, but there are many in Canada as well. And here's just a smattering of what I found online in terms of some of them are research clinics. Many of them are clinical programs that are trying to support people in their COVID recovery, people who are suffering from long COVID symptoms. People have also found support online. These are important places where people go and have found communities of long haulers, as they call themselves. This is a support group in Canada. Here's the Facebook support group. And here's one of the biggest web-based and Facebook support groups, which is COVID Long Haulers Canada. This is how Emma described her experience with finding community online.
This ER doctor that I visited told me to join the Facebook support group if I had any further questions, which has actually been a huge help because it's really nice to talk to people who've been going through the exact same thing as me. And they help with a lot of tips, like from different supplements, and it's nice to hear kind of what their physicians have been telling them to do and kind of their trial and error stories, so you can kind of take little bits and pieces out of it to try and do anything to get better, I guess. But it's really crazy to see that everyone's going through the exact same thing. I think that's the most surprising thing with the support group. And a couple of those things actually made me a lot better that they've taught me. Like, I've been doing better on the antihistamine diet, and they told me about the NAC supplements. But I guess the most helpful thing with that is if you have any questions and concerns, you just sort of reach out, and then a whole community of people will respond instantly and make you feel a lot better and kind of give you a sense of support and hope and, I guess, courage too.
I think it's a really important place that people go, and we talk about hope for a condition that a lot of people are suffering from and not able to get a lot of help for. For me, as a clinician and a scientist, I take hope from the fact that there is a lot of important research going on and we are learning about this condition. I think the most important is the RECOVER study, which is a $1 billion effort in the US to understand, prevent, and treat long COVID. People might have seen their website. We don't have final results or definitive results yet, but all of this is happening. There's also an important study called the CLOCK study in the UK that is unique in that it's looking at long COVID and particularly the mental and physical health of children. And we know that children and young people can get long COVID, probably less common than adults, but an important morbidity in children as well, and an important argument for vaccination of children. And the CLOCK study is going to give us a lot more information about how long COVID impacts children both mentally and physically. I looked on clinicaltrials.gov yesterday. I was heartened to see that there are 239 registered trials having to do with long COVID. So you can bet that there's going to be a lot of information coming out. We're learning more and more. There's an important Canadian trial that's being led by Andrea Gershon at Sunnybrook Hospital in Toronto. That's a multi-site study that's under the Canadian Respiratory Research Network, which is a national network. We are recruiting patients from around the country, learning particularly in the context of the Omicron wave, how many people got long COVID, how it affected their lungs, and focusing in on the respiratory symptoms of long COVID. So that'll be a Canadian data set that will contribute to our understanding here. I'm going to stop there, and I know that there are some further slides from Jenna as well that I can present, and of course we have lots of time for questions. I'll mention that you can find me at the Feed with Dr. G, which is our YouTube channel that we started in the context of the pandemic to help spread information that hopefully people would find helpful, and to also combat misinformation and disinformation on social media. These are the Feed with Dr. G is across all of these social media channels. So if you're interested in this kind of information, COVID and non-COVID science information, please check it out. I'll stop there. Thank you.
Great. Thank you very much, Dr. Gupta. Very informative. Now we'll have a few questions, both from the chat box and also from in advance. But again, if anyone has any questions, please write them in the chat box and we'll get to them now. We have about 15 minutes, which is great. Our first question comes from John. My question is, if asthmatics were showing up less in the hospitals for COVID, were they still going to the hospital at the same levels for their asthma, or were they just avoiding the hospital altogether? Meaning they were doing something holistic, like avoiding the trigger, staying isolated, and therefore not triggering their asthma, whether COVID or not?
Yeah, that's a great question. And I have to say that early in the pandemic, there were some unexpected benefits of the shutdowns that we saw in society. As you know, people were home, people were not interacting with one another. If they were masked, they were washing their hands. So we saw a lot fewer viral illnesses outside of COVID, non-COVID viral illnesses. And so we saw much less, for example, influenza, which is a major trigger of asthma attacks. So that as a result of less other viruses like influenza being spread, we think we saw less burden of asthma from that point of view. But we also probably saw an improvement in asthma burden in our healthcare system because there was much less pollution in the air. Industries were shut down, people were not in their cars. There were measurable improvements in particulate matter in the air, and we know that that particulate matter drives asthma flare-ups and COPD flare-ups for that matter. So we saw a lot less burden in our hospital of people getting asthma flare-ups and COPD flare-ups, and we think all of those factors played a role. So absolutely right. They were perhaps less likely to get COVID, or at least to present with their COVID, but they were also less likely to get flare-ups of their own disease, at least early in the pandemic, because of all of those restrictions and the impact on viral illnesses and clean air, basically.
Right, thank you. A question from Karen. Do we then need to use spirometry to distinguish between long COVID and asthma? With the long COVID, no asthma patients have normal spirometry.
Yeah, so I think they would. That's what we expect, that the majority of patients who have long COVID do have normal pulmonary function testing. And of course, if you have asthma, you will not ultimately have normal pulmonary function testing. You might have a normal spirometry, but if you keep carrying on and you do a methylcholine challenge test, you will eventually find the asthma. So a lot of patients with long COVID will start with a spirometry and then have a methylcholine challenge test because, again, it's so similar to asthma that we're looking for things we can treat. But you would expect the majority of long COVID patients to have normal lung function. As I mentioned, there's that 10 to 15% who had mild disease who still have abnormal lung function. And in the severe disease cohort, people who are hospitalized, even a higher proportion will have abnormal lung function. So it becomes a little bit trickier in those patients. But if you're seeing a response to a bronchodilator on the spirometry, or if you're seeing a positive methylcholine challenge test, those findings are specific to asthma. We wouldn't expect those in long COVID. So ultimately, we will still be able to identify our asthma patients if we do the appropriate testing when they're presenting with long COVID.
A question from Jonathan. Will we ever get a sterilizing vaccine, meaning the vaccine prevents you from catching and passing it on?
I wish we would. I think it's very unlikely based on the technologies we have currently and the kinds of vaccines we have. The idea with the vaccine is that it gives you antibodies. So the idea, even from a mechanistic point of view, is not that it would prevent you from getting the illness, because the antibodies can't do that. The antibodies can only act once the virus is inside of you. So conceptually, vaccines don't prevent you from getting it. But a very effective vaccine would enable you to mount an immune response very quickly. But as we've seen, not quickly enough, particularly with the variants that we currently have, to prevent you from getting enough of a disease to pass it on to others, for example, and even just a mild illness. So it doesn't look like we'll get to a point where the vaccines are effective enough that the antibody response is so robust that it'll prevent any illness and prevent people from passing it on.
Thank you. And from Susan, is there any information on COVID in patients on Xolair treatments?
Yeah, so I haven't seen anything specifically on Xolair, but the data I presented on acute COVID disease and asthma is all asthmatics considered, but there are some data sets in severe asthma that suggest that patients with severe asthma are more susceptible to severe COVID disease. That's been shown in a few different studies. So generally speaking, although asthma in general is not a risk factor for severe COVID, patients with severe asthma who are, and usually that's been defined in studies as patients on biologics, do seem to be at higher risk of severe COVID. So we think of those patients differently, and we're much more careful with those patients in terms of assessing their risk of illness.
Great. A question from Susan. Is double masking still considered a benefit?
Yeah, so masking in general is still considered a benefit because there's a lot of COVID out there in the community. Mostly that masking is protecting others around you from your virus. To some extent, it's protecting you as well. Double masking is it's a strategy to make masking more effective. And the idea there is that a mask is often loose, and that sort of defeats the purpose of a mask. If you have air escaping from above or below the mask, whether you're breathing in that air or breathing out that air, it's not being filtered by the mask. And the concept of double masking is that really what's happening is that the role of the second mask is to make the first mask snug. So you're using two masks to enable yourself to get a good mask fit. And that's really what double masking is all about. If you have a proper mask, for example, a surgical mask, you don't need two layers or two masks for their filtering capability. You're more using it to get you that good fit. Of course, if you're using a mask like an N95 mask, it's already fit, so you don't need to double mask. But the concept of double masking is still helpful if you're using a surgical mask, for example.
And a question from Tracy. Do asthmatics who test positive for COVID qualify for the pharma prescriptions of Paxlovid and or Remdesivir? Sorry if I'm pronouncing that incorrectly. If they meet the window, and if so, has this treatment been shown to decrease symptoms or shorten infection time?
Yeah, so the candidacy for Paxlovid and Remdesivir will be different by province. In Ontario and most Canadian jurisdictions, it would not, having asthma would not be enough to qualify you. You would not be considered high risk for the reasons we talked about. Just having asthma, you don't actually have a higher risk of severe disease, and those drugs are reserved for people who do have a higher risk of severe disease. In terms of their efficacy, the efficacy trials that I've seen have not given subgroup by asthma, subgroup by specific diseases like asthma. We have great sort of larger general data sets that show that they're very effective, these drugs, but we don't know if they're particularly effective or less effective in a group like patients with asthma. We wouldn't expect them to be fundamentally different in that group, but most importantly, just having asthma would not be enough of a risk factor for severe disease for someone with asthma to qualify for those drugs.
Excellent. Does air pollution from living near highways increase asthma and long COVID symptoms?
Yeah, so there have been studies looking at particulate air matter and particulate matter in the air, and living near a highway means more particulate matter, and that does mean a higher incidence of asthma in people who live near those environments, and also means a higher incidence of symptomatic asthma, so flares of asthma and day-to-day symptoms of asthma due to that particulate matter. But we don't have data that I'm aware of on incidence of long COVID as a function of air pollution. Certainly, there have been studies looking at incidence of COVID as a function of air pollution, and there have been data suggesting that COVID as a virus is more common in places with more air pollution, and that might have to do with people being more susceptible to viral illnesses due to air pollution. But I haven't seen anything on long COVID specifically.
Is taking a Flovent putting people at higher risk of COVID-19?
Probably not. I mentioned earlier that one of the treatments we use for COVID is actually inhaled corticosteroids. We think the anti-inflammatory effects of inhaled corticosteroids like Flovent might actually mitigate the severity of the COVID virus, COVID disease, for a few different reasons. So less inflammation to begin with, and possibly down-regulating that ACE2 receptor in our airway cells that the virus uses to get into our cells. And that inhaled corticosteroid actually reduces the amount of that receptor, so it might make it harder for the virus to get into our cells. So it's probably the opposite. It's probably that these inhaled corticosteroids are protecting us from severe COVID disease to some extent.
Question from Ashley. I'm an RT in our community hospital. I do our QA for our spirometers, and I know my normal baseline spirometry values. Post-COVID, my spirometry was very abnormal, and now I've developed reactive airway disease. It's been 10 weeks since my COVID infection.
Yeah, so I'm sorry to hear that, and that's, it could be that you're in that smaller category of people who do have abnormal lung function after their COVID disease, partly a function of the severity of the COVID, but even in mild COVID cases, we do see it in some people. What's interesting is you're talking about reactive airways disease, and you're sort of outside the typical window where we might say a reactive airways disease is just still sort of related to the virus or the post-viral inflammation. And if that persists, then it may be that there is a component of asthma. And as we talked about earlier, in many cases, it may be that people had mild asthma, but it was never manifest. It was never obvious. They never had to get testing. They never were aware of it. But after a severe infection, like a COVID infection, people became aware of it, and then the testing finally reveals it. But it doesn't necessarily mean that the COVID caused it. It could be just that the COVID caused enough symptoms that we then went looking for it and identified it. So that's where it gets really murky and confounded and hard to distinguish. But ultimately, if we find a diagnosis like asthma, at least it gives us a therapeutic target. At least as a provider, I can say, well, here's something I know I can do something about, and perhaps at least help the respiratory component of your long COVID symptoms. So hopefully you're getting access to those kinds of treatments for the asthma that's been identified.
And from Sarah, what else can Canada be doing or is needed to support people living with long COVID, especially those with existing lung diseases? Currently, there seems to be a bit of a patchwork provincial approach. Can there be more done to support long COVID patients nationwide?
Yeah, I think there should be more done. I worry about whether our health systems are prepared for the burden of disease that's going to come from long COVID. And it's not only these people that we sort of talk about non-specific symptoms that often they had mild COVID and they're left with non-specific symptoms, but it's also a whole bunch of people after COVID having major medical events. And we know that people are more likely to have strokes and heart attacks, more likely to have mental health issues after COVID. All of these are going to impact our healthcare system. As you know, we are a federation and healthcare is controlled provincially, and different provinces have had different approaches to managing the problem of long COVID. I don't know if it's politically feasible to have a federal approach to this problem, other than the federal government recognizing the importance of this, putting money into research for this, which they have to some extent, and we'd like to see more. But I think ultimately these decisions will be made by provincial health ministries. And I hope that there will be continued support and increased support for long COVID programs. And one of the programs that we think might emerge is some type of rehab for long COVID. We're already doing that to some extent, and we're borrowing from principles of pulmonary rehab that we do for diseases like COPD and pulmonary fibrosis. And we're learning that some things work and some things don't work in the long COVID population. But I think one area that we would love to see support is for pulmonary rehab programs specifically for long COVID. And that's where I think there is going to be a huge need. And we hope we can get funding for that from our provincial governments.
Great, thank you. We have a few more questions, so we can keep on another 3 minutes or so. From Sylvia, if you were vaccinated and developed COVID with symptoms of breathlessness, fatigue, and muscle pain, would you expect a change in daily peak flows?
Again, not so much as a function of the other symptoms, because as I said, only a minority of patients who are symptomatic will have objective findings on testing. But there is a small percentage of people who will have some changes, for example, on spirometry. And one would expect that they have changes. If they have significant changes on spirometry, they would also have a reduction in their peak flow values. So a peak flow is not as reliable or as meaningful as a spirometry. But if there are changes in peak flow that you're seeing after a COVID infection, it's worthwhile then going to see your provider and trying to get that spirometry test as well to see if it also has changed compared to your baseline pre-COVID.
Great. From Lorraine, can an asymptomatic COVID with a positive PCR test lead to increased asthma symptoms, such as increased sensitivity triggers like smoke, 6 months later?
Yeah, it's a great question. So it looks like asymptomatic disease can cause long COVID, perhaps less likely than severe disease, almost definitely less likely. But certainly many of the patients that we are seeing with long COVID had mildly symptomatic or even asymptomatic disease. And what happened is their long COVID symptoms came later. So they had the virus, they had an exposure, and then they never had the viral symptoms. But a few weeks later, they started getting very typical long COVID symptoms, and they traced it back and said, well, probably I had COVID at that time. And in some cases, they have proof of it with a PCR, and they still develop long COVID symptoms. So certainly even an asymptomatic case can lead to long COVID symptoms and can lead to hard objective findings, like changes in spirometry, but also more subtle findings like changes in sensitivity to triggers. And this might be either the long COVID itself, or it might be the COVID virus sort of triggering and making the asthma more active, and therefore making you more sensitive to your asthma triggers. And that's where it becomes really hard to tease out which one is which. And we would always say, well, the treatable thing, the thing we understand better is the asthma. If you're more sensitive to smoke now, let's intensify your asthma treatment and see if that makes you better.
Most kids I find don't have any symptoms, but a few have had a lingering cough after COVID. Is this because of their asthma?
Yeah, I mean, again, it's so hard to distinguish. Is it a post-viral cough? How long after the COVID is it? Is it that the virus, like many viruses do, has sort of triggered the asthma, caused some inflammation, and that inflammation is often self-perpetuating, whereby after a viral illness, there's a general loss of asthma control, and we need to intensify therapy, sometimes by increasing the inhaled corticosteroid, sometimes by giving systemic steroids. So it could be that. And that's probably where I would target first to see if it helps. But it could also be a manifestation of long COVID that has nothing to do with the asthma. And that's important because cough has been reported as one of the pretty common respiratory symptoms of long COVID. And that's where it'll be hard to distinguish. And in some cases, the only way to distinguish will be to do a trial of therapy and see with asthma therapy if it gets better or not.
Okay, and 2 questions left. Susan, with restrictions lifted, can a student return to class masked and stay safe while in an environment of unmasked students? From what I understand, the mask alone is not enough for protection in non-distance, indoor, and poorly ventilated spaces.
Yeah, so a mask is better than nothing, but absolutely a child can catch this virus despite wearing a mask, unless they're wearing a fit tested N95 mask all day, which is unlikely to happen. And so surgical masks are good, but surgical masks come off during lunch. Surgical masks, particularly in kids, slip below the nose. Kids touch their mask, they touch their face. It's very challenging when there's a lot of virus around you, and particularly when not everybody is masked. And as I mentioned earlier, the masks are more effective at preventing your droplets from getting out and affecting others than they are at preventing other people's droplets from infecting you, particularly with surgical masks. So if none of the other kids are wearing one, that means there's a lot of droplets in the air. Many of those droplets could have the virus in them, and your mask will only go so far to protect you. It will offer some protection, but it's not nearly as good as everybody wearing a mask.
And the last question from John, should we be prepared to not only catch COVID on a repeating basis, but also potentially to develop long COVID in the long-term future?
Yeah, I think the likelihood is that most people, except those people who really don't leave their homes and have no exposures at all, outside of those people, most people, I think, in society will get COVID. In many countries, that's already happened. A vast majority of people have seroprevalence evidence that they've had COVID before. With respect to the question of whether we can catch COVID again, we're actually going to release a video on that. It's a bit of a myth buster on the feed with Dr. G tomorrow, because a lot of people think you can't catch it twice, but you absolutely can, particularly because of what we've seen with respect to the change in the virus. So particularly with how different Omicron is than prior variants, it's very clear that you can get COVID, particularly you can get an Omicron infection, even if you've had a Delta or Alpha or original variant infection before. Just the same way that the vaccine that was designed for the original variant isn't as effective against Omicron because it has changed. The virus itself has changed. Similarly, your prior immunity is not as effective against Omicron. So we saw lots of repeat infections in our BA1, in our initial Omicron wave at the end of last year and the beginning of this year. So absolutely. And if the virus changes further, and we're seeing that with BA4-5, people who got BA1 Omicron are able to get it again with BA4-5. So as the virus evolves and changes, our prior immunity will not be foolproof and we can get reinfected. Still less likely to get severe disease, and that's important to recognize. Must we be condemned to long COVID? Hopefully not. Hopefully getting COVID after vaccination, getting COVID after prior infection where you have that natural immunity definitely means you're less likely to get severe disease, which in itself means you're going to be less likely to get long COVID. But hopefully even for mild disease, we'll see less long COVID. We don't have data on that, but that's my suspicion, that we're going to see less and less long COVID because we have more and more of a immune population through vaccination or natural infection or the combination of both.
Wonderful. Thank you very much, Dr. Gupta. So for the next slide, just a very quick mention, Asthma Canada does have a bilingual asthma and allergy helpline, which connects Canadians with CRE for information and support. So if you have any further questions, please email us at info@asthma.ca and we'll be happy to help. And then our very last slide. So we are at the end of the time. Dr. Gupta, thank you again. Excellent presentation. That was a great Q&A. For everyone joining us, I'd be remiss to say, if you found the work that Asthma Canada does to be helpful, please consider making a donation at asthma.ca/donate. Any amount is appreciated. Thank you again, everyone. And again, we will be uploading this to our website at asthma.ca. Have a great day.
Thank you.